Well, thank you everyone for inviting me again. It's a pleasure to be here. My topic today is an integrative approach to oncology. It's going to talk about how to consider oncology a field that needs to be highly personalized and individualized, and what the factors involved are, and how, since 1 in 2 of us in the audience will get a cancer or experiencing it presently in our lifetime, then how you are able to handle this environment, so to speak. Okay, Bert, you have to, someone's got to run it. Okay. The quote that I sort of like to start every talk with, this is the one that's best suited, I think, for this topic of oncology. I remember in
Could you read the quote?
Oh, okay.
Some people may not be able to see it.
Miracles do not happen in contradiction to nature, but in contradiction to that which is known to us about nature. So when I graduated from medical school in 1977, we were 7 years into the war on cancer, and we were going to defeat it in 10 years. So it was about 3 years to come to the time we were defeated, and that was some 35 years ago. So these are mythologies that we have to dispel right now. The definition of oncology is interesting, and that is, sorry.
Oh, got a delay. You need to.
Okay.
There you go.
It's simply the specialization in the diagnosis and treatment of cancer. Our standard of care has evolved over time to the point where we are, or you could say it lacked evolvement over time, because it was set into stone back in the early 70s and has evolved since then in the same methodical way. So when I was studying pathology for 4 years at Albert Einstein, I'd say the least sophisticated of the specialities in the Renaissance period of immunology at that time and molecular biology was the oncologist, because at that time they were focused entirely on methods of changing protocols from one protocol to the other, from combination A, B, C to A and C to B and D to E and F and so on, and changing those types of paradigms in a very naive way to seem to find the magic solution to each and every cancer, but that has been exceptionally naive from the very beginning. So, reading this, that some of you can read with that have normal lenses, we started this in World War II with the issue of nitrogen mustard, and ultimately a nitrogen mustard prototype was used to temporarily cure certain patients with non-Hodgkin's lymphoma, and this led to using antimetabolites, in this case methotrexate, to cure patients with ALL, at least temporarily. And those cures were, those remissions were usually in the order of months. And these were done in children. So it was very, very encouraging. And the head of the then head of the Dana-Farber, the Professor Farber, who then headed the Dana-Farber Cancer Institute, was instrumental in being the father of chemotherapy. But that led to using combination chemotherapy, and then higher doses of chemotherapy, invasive surgery that led to more invasive surgeries, and we thought that bigger is better, and larger is better, and more concentration is better. And then we ended up with at least 6 different prototypes of cancer chemotherapy drugs that now runs routinely in a routine oncology practice. We learn about 70 to 100 chemotherapy agents and know them in great detail. And they lead to bone marrow suppression, as you all know, and all these toxicities that are listed here. And this has remained the single biggest barrier to success for an agent like the concept of chemotherapy. And it's anti-personalized. So all chemotherapy clinical trials deal with the average, deal with the mean. So if you have an average case, you will receive benefit in 33.3% or 39% of cases, and beating placebo in about 25% of cases, or beating the prior combination by 8 percentage points for a total of 6 months. That is a common approved drug in the United States or worldwide. So if you can get an additional 2 months of life from a new combination chemotherapy drug that costs $30,000, $40,000, $50,000, $60,000 more, the FDA has approved these drugs repeatedly over the decades. So the concept is that we need an adequate intracellular dose that allows us to get lower concentrations of drugs, and yet in order to get intracellular doses of standard chemotherapy, we have to get high doses which lack tissue specificity, and that creates the drug effect. So what have we managed to accomplish in the last 50 years, 60 years? We've done a very good job with plumbing, with cerebrovascular and cardiovascular disease. We have done fairly poorly with regards to altering the relative state of immunosuppression that the average person is under, given the level of toxic load that we have, relatively speaking, with multiple new generations of antibiotics and new antiviral agents. And we have done essentially nothing with cancer deaths. Now, this is despite early detection with mammograms and colonoscopy and with PSA levels for prostate cancer. And so despite that, we end up with the same result. So it leads to the conclusion, in my opinion, that either the host is more degenerative over time and then therefore less adaptive, even with more therapies, or the environment has changed and the cancers are now more aggressive. I think both of them probably play a big role. So why is that? There are experts in this room more than I in toxicology, but part of the answer lies in our toxic load. So whether it is in utero and at the time of birth in the cord blood, which is this is the one that gets me the most upset. According to chemical analyses of cord blood samples from newborns, 287 toxins are identified. This is 10 years old in umbilical cord, and 180 of which cause cancer. And we obviously have a dysregulated system here, which doesn't pay much attention to this. So we have a higher level of toxicity today than we do 50 years ago, more than 10 years ago, 20 years ago, and this is progressively getting worse and worse, so we have less adaptive qualities. We have an expert in methylation pathways here, and Dr. Kunin, who could talk for 3 days on the effects of toxicity of these types of toxins on the methylation pathways, on our metabolic pathways, on our detoxification pathways. So we have less ability to compensate, okay? And in routine random samples from patients, from people, routine normal people, we have tremendous exposure to environmental chemicals. And unfortunately for us, because we're not fish, we have to breathe, and we all are breathing the same air, and the air is ultimately much more polluted than it used to be. So we have a certain toxic load that we have to deal with. So I think that's off to the side. So we're going to begin the discussion today about an integrative approach to oncology and what that means. So the definition of it is a systemic, patient-centered, healing-oriented, whole-being-oriented, and functional approach that individualizes the causes and treatment of cancer using all available therapy. So this group, of course, is at the forefront of advocating for access to all available therapies. And I cannot have this discussion at UCSF. I cannot. I've tried it at UCSF. I've tried it at Johns Hopkins beforehand. It doesn't work. And so we're here today to discuss it because this is an open forum. Now, integrative oncology is rapidly evolving. I've just heard from my colleagues at UCSF that UCSF is hiring an integrative oncologist. Only part-time. Because they're not sure that there's be a full-time position for her. They're not quite sure yet. I'll be the first cardiologist that practices integrative oncology at UCSF, and that'll be a good idea. But we obviously have experts that can look at any form of different alternative therapies. And I'm going to argue today that someone challenged with this challenge, even conceptually going forward, you will need to study multiple lineages in order to be able to be intelligent and be able to repurpose your metabolic systems in order to do the job if you or your loved one have a diagnosis. And then we'll also talk a little bit about how one could understand how you could find the evidence for early detection and do something about it. So the concept looks more like this when you look at integrative oncology. And this is supposed to be a circle, you're supposed to see this. And of course, I'm not going to talk about a lot of the different forms of personalization. But this is where you see this little circle here, this oncology, little disease-centered circle here, and the larger circle. And we're, of course, this is the typical graphic that you see. And I'm going to argue today that it's also naive and also not enough. So we have to seek some combination of the best of Western medicine with practices that come from a variety of thoughts. Natural medicines, nutrition, homeopathy, Chinese medicine, sound, light, laser therapy, hyperthermia, and any variety of other modalities. And of course the goal is to have a functional-based medicine approach and treating all levels, and I think Dr. Saputo is going to speak about much of this as well. So I like a little bit of a different form to my graphic, and I'm going to take you through a little bit of the world in the next 5-10 minutes of what I think will be a more robust approach to what is the best of Western medicine. What can you actually acquire from that form of medicine to use in your own other formulas that all of you, many of you in the audience are already experts in. So I will share with you some of my expertise on the Western side. The first concept is the concept of molecular targeting. We knew back in the 70s that we started off with immunology being T cells and B cells. And then we've come to the point where we have 500 surface markers typing 500 different cytokines, chemokines, and different cell types. That scratches the surface of the different cell markers that will be now, they're already now available and will be available over the years to come on tumor markers. So the tumor markers not only specify where the tumor comes from, but they also specify the biology of the tumor. Is it aggressive on vascular and creating its own vessels? Is it aggressive on the ability to create proteolytic enzymes that it can aggressively enter a new tissue? Is it aggressive because it can resist chemotherapy drugs? What is the nature of this tumor is defined largely by surface molecular targets and markers. This field is exploding. There'll be diagnostics, there'll be therapeutics for this, but the point is there is this whole field that's emerging, and now we have entities that I'll share with you in a second that actually identify why it is, based on this type of technology, why is it that curcumin works so well? Why is it that metformin, a drug that lowers blood sugar, works so well, but it also works on these targets? So that we'll have the merging of molecular medicine and natural medicine in this particular way, in a very elegant way, I think, in the next few decades. The concept of chemotherapy, none of us want to do it. None of us want to go through it, of course, and the reason is the toxicity level, but there are approaches which I will talk about to lower the dose and to have equal efficacy or even greater efficacy, called IPT. I will say at the very end, though, that, so let me skip over. I only have 5 minutes to go. There's a test in the United States that's now available in the United States. It's not covered by insurance, where you can draw your blood and measure for the presence or absence of circulating tumor cells. Many of you are nodding because you've heard of this so-called grease test. If you have circulating tumor cells, you can identify what agents, whether they're chemotherapeutic agents or natural agents, are sensitive to kill your tumor cells. So if you have cancer and you have therapy and you want to know whether you're truly in remission, you can get this blood test. Or if you don't know what to do, because everyone's going to get radiation chemotherapy, you want to know where you truly stand, you can measure the load of tumor that you truly have in your body, because we normally can get at the primary tumor. What we don't understand is how to get at metastases. OncoBlot is a great new insurance-covered test that will measure 80 different proteins that circulate in the blood, but you have to have a tumor the size of like 4 millimeters in order for it to be sensitive enough to find it. The RGCC test, you can have a microscopic amount of circulating cells without any visible tumor. And then Caris is a type of company that you should look up, because these are the companies that you will be able to ask your oncology surgeon to send to the laboratory to type the tumor itself, to type the aggressiveness of it, to type the molecular biology of it. So IPT, it's all run by the Garcia family. DPG 1, 2, and 3. They've run it for the last 100 or so years. It was first started in '46. And the concept is that tumor cells have much higher concentrations of insulin and IGF-1 receptors, and you can starve the tumor cells by treating them with insulin, dropping the blood sugar very low, and then providing low doses, which means 10 to 15% of chemo doses, which are not toxic at that level, and you provide tumor cells and provide the patient with chemotherapy at that therapeutic window. And at that time, the tumor cells preferentially concentrate chemotherapy within their cell membranes. So insulin receptors are in almost every cell type, and it increases, the effects are increasing permeability, increasing the intracellular dose levels and concentration levels. So this is a viable alternative in the United States today. And there are scientifically based studies that are beginning to come up with the physiological basis for why this works. It is extensively used throughout Europe and Russia, as well as now in the United States. There are about 50 or 100 doctors now practicing IPT therapy in the US. And it's simply a biological modification using insulin in an off-label way to increase drug concentrations in a selective way. These are the organizations that now exist on the Integrative Oncology side. I want to say from my perspective, today we're going to be focused on different aspects of this. I will not talk about ozone therapy today, but it is to me one of the pillars. Within the oxidative medicine approach, there are redox molecule products out there that a few of us know about and can talk to you about later, that are important in resetting the metabolic pathways. But I think that the future holds the greatest support here on the immunotherapy side. We could provide an entire day's worth of intelligence on this level. But there's extensive work throughout the world now on training your immune system to fight your own tumor. And it's intuitively very elegant. But we will lag behind the rest of the world in this for the next decade or two. But you have to be aware of it because there are centers throughout the world with a great deal of intelligence on this level. And my last message, and now that I'm a minute over, is that obviously the diagnosis is a wake-up call. It requires healing on the entire level. And it is not a purely intellectual exercise. Thank you.